Hello, everyone. I am JD Osborne, Vice President of Surgical Products and Services for Corneogen. Thank you for participating in today's webinar titled Keratoconus of Refractive Surgery, a Paradigm Shift in Approach and Performance. During today's webinar, we will discuss what Dr. Gulani refers to as refractive mindset approach to keratoconus, modern therapy options, where intact corneal implants fall in the treatment spectrum, and you'll get to see a full spectrum of case studies from mild to severe, including surgical complication resolution. We will use the last 10 to 15 minutes of the webinar to answer any questions that you have. You can submit a question anytime during the webinar by using the questions box in the upper right-hand corner of your screen. Click on the plus sign. It will open a text box for you to write and send your comments or questions. We will do our very best to answer as many of them as possible during our allotted time. Before we start, let me tell you a little about Dr. Gulani. Dr. Arun Gulani is a world-renowned Lasik, cataract, and corneal surgeon and pioneer of Corneoplastique. He is the founding director and chief surgeon of Gulani Vision Institute, located in Jacksonville, Florida, the global CEO of Gulani Vision Surgery Suites, adjunct clinical professor and externship proctor at Midwestern University in Chicago, and is a member of the fellowship faculty at Universitas Miguel Hernandez in Alicante, Spain. Welcome, Dr. Gulani. Please join us.
Thank you so much for the invite. Pleasure to be back again, JD. And
absolutely, Dr. Gulani. At this time, I'm going to turn it over to you.
Okay, everything visible now?
Perfect. Yes, sir.
Lovely. So it's a pleasure to be back again, another Corneogen webinar, and I'll be sharing today decades of my work as a refractive concept of keratoconus. And may I encourage everyone today to believe that keratoconus patients can see, and our aim should be to make them see without glasses and contacts in most cases. So keratoconus, as we all know, is a condition of the cornea which is dystrophic. It's non-inflammatory in many cases and mostly impacts vision by affecting refractive errors besides the anatomical stability. I'd like you to look at these things right here. These patients, all of them, in demanding professions, all of them, from pilots to firefighters to surgeons to attorneys to models, and this is patients in the one particular day, all of them are seeing 20/20 and without glasses. So this is possible. I don't believe in severity of keratoconus. I believe we must fight for their vision. Once you have looked at all this and this makes any sense, then we can proceed further. Another very important thing about when I teach or speak is I love to show patients, because I always believe a scattergram or a statistical chart can always be manipulated, but a fully paying high IQ patient on camera always speaks the truth. So I would keep showing patients. This is also my way of encouraging patients and surgeons, my colleagues from all over the world, to see the reaction of people when this pattern of approach is taken. That's why this article, I said, show me the patients. This was stolen from me by Jerry Maguire when they said, show me the money. Raise the bar. Dependence on contact lenses and delaying transplants is not a goal. Delivering vision without glasses and contact lenses should be the goal. There is no harm in landing short of your goal, but at least try. And then you can always have contact glasses, but the first shot is try for vision. I will show you in this case my mindset and thought process, which is actually the biggest part of what I'm going to discuss today, and encourage you to change your mindset. So if you see in this particular patient, this patient was referred to me, was in a potential lawsuit with his surgeon, a brilliant colleague, and this patient had a premium cataract surgery done and in a keratoconic eye, and the doctor landed with a hyperopic surprise. And additionally, he proceeded to do a YAG capsulotomy thinking that'll help him. So now the patient was very angry. He was left hyperopic and of course had high keratometry of keratoconus, a central anterior scar, a premium lens in place with an open PC. So here's how I approach these cases. This case was sent to me as usual from his excellent surgeon. He sent him over saying, Doc, I know of your skills and I know you like 20/20, so you'll take him, you'll exchange his lens despite the open capsule and bring him to perfect vision. But that's not how I think. So when I accepted the patient, my whole mindset is vision. What is that one surgery which can get me emetropia? So again, remember, I line up all the errors, as you can see here, and I line them up in my 5S systems that's been published 3 decades ago, where I talk about sight, scar, shape, strength, and site of involvement. So here, the pins that were involved, if you may, are the corneal scar, astigmatism, pseudophakia with an opal capsule, hyperopia, high keratometry. So what is that one surgery that will correct this problem? In my clear system of 5S system, that one surgery which will clear the central scar, flatten the central keratometry, correct to emetropia, and increase the optical zone, such giving even better night vision, is myopic surgery, myopic laser technique. Now the problem is patient's hyperopic. So how do you make him myopic? So you see how my thought process didn't even jump into surgery to show off my skills, exchange the lens with an open capsule. That's not the point. Patients want vision. So I completely disregard the surgical side and I start thinking vision. So when I said this, even the patient becomes your teammate rather than being angry at his surgeon. I tell him my plan is to make you myopic. And he goes, well, okay, how do we get myopic? And here's what I did. I call this going to Paris via Iceland. So the patient has to have patience and confidence in you. So what I did first is, because I wanted myopia in this case, with a deep chamber, scar, high K, I performed a piggyback lens in this patient. And that's what happened to his vision. His vision became dark, horrible, and bad because we were literally in Iceland. This is a cold place. He couldn't see the Eiffel Tower yet, but my ticket to him was to Paris. So by doing that, I turned him into a myopic astigmatism. And then I proceeded 3 months later to perform my superficial laser technique and brought him straight to emetropia, which also cleared his scars, if you know my concept of corneal scar corrections, and straight to perfect emetropia, clear center, left his patient's lens in the eye, and the patient is 20/15 without glasses. That's better than 20/20, got his pilot's license back. So you can see the journey right there. And again, the important point here is how vision planning, to me, is more important than surgery. Surgery happens. Here is another patient, and I do not like doctors constantly wasting their energy grading the keratoconus, staging it, talking about severity, and then getting paralyzed and doing nothing. In fact, I believe all kinds of keratoconus, including surgical ectasias, can be corrected to excellent vision. Here is a patient with 9 surgical complications, including hexagonal ectasia. And how did I plan her correction? Fuchs, ectasia, high keratometry, 24.5 diopter astigmatism, and what we did here. So if you see in this patient, I first controlled the cornea using Intacs and brought the astigmatism, irregular astigmatism, to 1.4 from 23.5 diopters. All right. Now I call this an intelligent and measurable cornea. And then I go inside the eye and perform premium surgery for this patient, taking us straight to 2025 uncorrected. So if you can see this, I'll go through this fast just to share with you concepts before I begin the rest of the talk. Dystrophy along with associated cataract and high keratometry of 88 with high irregular. Remember, 88 diopters keratometry. So watch what I'm doing here. Manual dissection, putting 2 intact rings to hug that irregular central unstable hexagonal keratotomy cornea. So I'm recreating her balance in the cornea, if you manually, and please notice the reflex in the center. That's what I call my titratable intact technique. I watch that central reflex of the light of the microscope as I'm doing this. And remember, I'm using manual technique to use resistance rather than cut through, which will be dangerous because if I go any more central, I'll be through the hex K. If I go any more periphery, I'll be in the limbus. Notice the reflex is a perfect circle. Very rare instances where I cross-link immediately in these cases. I always like to stage, but here, because the reflex is perfect, I go ahead and cross-link right there. Patient reached an excellent outcome, down to 1.4 from 23.5 and 88, dressed up, very happy, and keeping her stable, I measure her and now proceed confidently to premium toric cataract surgery, straight to emetropia. Again, please notice my desire to always go beyond surgery. It's the vision that I'm after. Very, very important focus vision. The surgery to me just happens. And again, surgical skills, very important. You want no stitches, you want to be artistic with drops. All those things are very important, but understand the vision drive here. Again, remember 88.8, that's about 90 keratometry cornea, 24.5 astigmatism, written off by every surgeon all over the world as nothing can be done. Two-stage techniques, brief techniques, topical within minutes, straight to 2025. And she's back into her life. Actually, she took up a nursing career to help other people. Free cue for your great. Next. So the way I think this has already been written up in iWorld as a Gulani planning system. Basically, I talk about GPS. You cannot do a technique and see how you land. You have to plan the destination, the vision, and then come back to surgery. So to me, this is my sequence: vision, then plan technique, and then technology. And this is where I spend my time, planning. So the 3T systems involves over 40 different techniques, technologies from which you can choose. And that's why I call this think outside the cone. Now let's go into the system I will align for you tonight, which is mindset. So how do I think? If I have a patient whose best corrected vision, remember this is the most important box, the best corrected visual acuity. If that's better than 20/40, I'm thinking visual surgery. So forget everything else you've read and confusing things that are constantly coming out. Two simple parameters: structural surgeries and visual surgeries. If it's more than 20/40, I'm thinking visual. We cannot deprive this patient, and I want 20/20. Refractive error, astigmatism more than myopia, pachymetry more than 400, stable, topography regular, no pathology like scar, ectasia, lens, or cataracts. Here's how I would proceed. That's my choice of surgery: LaZrPlastique and superficial laser technique straight to vision. For example, in this case, you can see these immediate reactions of patients. Advanced keratoconus patients.
Very irregular astigmatism. Can you see anything at all? I can see. This is an immediate difference. This is, oh my God, like I am tingling from the inside out. This is fantastic. Any pain, Hector? No pain whatsoever. None at all. This is great. Very proud of you. I kept my promise, no pain.
So the reason important for you to see the reaction of these patients who've been told for years that nothing can be done and their options are hard contacts or expensive contact lenses or let's delay your transplant, that's incorrect. And the last thing you want to do is cross-link them and not correct them, which we'll talk about later. Here is the patient, another one showing you how the laser techniques work in these cases. Having those parameters I just discussed, you can see here, brought the astigmatism from 1.7 to straight 0 diopters. This patient is a firefighter who works at night and a paramedic, and vision is better than 2020, 2015. Again, this can be also, laser techniques can also be used to multiple complication patients that fly to me who've had many previous surgeries, as I mentioned to you, without the GPS being in place, right? Surgery was done, vision doesn't land where you want, and now the patient is stuck. So this case went all over the world. He had cross-linking done twice, ICLs, everything, and was left with visual errors. We did laser surgery straight to 2020. Here you can see my scar removal concepts. As you know, I've shown this multiple times in my in-cornea, on-cornea techniques, even acanthamoeba scars in these kind of patients with Keratoconus. You can see immediate reactions of these patients under the laser and how they see. So having a superficial scar is not an issue.
I just finished doing laser on your scar, acanthamoeba scar. Can you tell any difference? There's a lot more clear, things are sharper, the image is sharp. Any pain at all? No pain. Well, I'm so proud of you. How many years have you suffered with this blindness? 14 years.
I want you to remember that. Scars, as you know, my in-cornea and on-cornea techniques, the scars are removed as refractive errors, not PDK, refractive errors. I'll stop there for a minute, Jerry. If there's any question regarding this level 1, which is laser techniques for keratoconus, straight to 2020.
Yes, Dr.
JD?
Gulani, we do have one question that I believe is pertinent at this time. When staging a patient when cross-linking, can you discuss exactly when you choose to cross-link? How long after intact implantation?
So whether it's intact or any other surgery, you want stability. Remember my concept. I'll come to cross-linking in my next portion of the talk, where I talk about the keratoscoliosis concept. Cross-linking to me is a permanizing procedure. You use it only when you have achieved your vision outcome and you have proved stability. So anywhere from 3 months to 6 months, I would go in at that time. All right. Next section of our talk. Again, I put in this algorithm for you. So I've kind of brought out how I think, and then we'll go into the surgery. So let's take the best corrected visual acuity, again, more than 20/40. Myopia, more than astigmatism. Good pachymetry, stable, regular, no other pathology. When there's high myopia and stability in a keratoconus case, again, I go visual. Here I would use my ICL, either in a myopic mode or toric ICL with toric astigmatism with myopia, straight to vision. Again, remember, I'm disregarding the cone as long as I have stability and measurability. And please don't go into the other discussion that wastes your energy, keratoconus, keratoglobus, PMD. It doesn't matter. 3 decades I've been correcting all these cases. It doesn't matter. Do not waste your energy and confuse the patient. Take them to vision. So that's when I would use ICL. Having used ICLs and phakic implants for, again, way before the FDA approval in the US, all kinds from different kinds, either the Japanese, the French, Dami lens, the m.o.i.s.t, the ICL, worst lens, all these lenses, the vision ICL most commonly used here is which I use in these cases. Very easily you can do this. Any of you can do this, no special skills required. And these patients are thrilled seeing with keratoconus. You can even correct these patients of keratoconus who may have surface disorders with amniotic surgery and then put in ICL to perfect vision. So no limits. Now I'll take you to another level of thought process. Vision better than 20/40. Again, could be astigmatism, hyperopia, myopia, good pack, stable, regular, cataract. Cataract and keratoconus, very common, right? Nothing to worry about. In fact, most of these patients, by the time they're cataract age, they are pretty much cross-linked naturally. So again, do not jump to cross-link. There are patients who may still progress, but if it's stable, go with that. And you can perform very intelligent toric premium lens cases and bring these patients to excellent vision. If you see even in this case, the pre and post-op corneal topography looks the same, but the patient is 20/20. Here he is with the toric implant in place. And there are various technologies available. In fact, I've also used one of the first Vivity torics and keratoconus when it came out many months ago. And you can see that patient right there, thrilled with their vision. Very, very important to understand. Even in complex cases like this, patient who has a severe astigmatism, 11 diopters, nystagmus, ocular albinism, dense keratometry, keratoconus, nystagmus, everything, and high myopia. In a patient with albinism, with dense cataract and a penetrating corneal transplant that was done. So you can see there is no limits. Once the patient is stable, you can take them straight to vision. Straight to vision. That's the point of today's webinar. Now let's go to the next level here. Vision better than 20/40, astigmatism, hyperopia, myopia, more than 300 pachymetry, stable, regular, no pathology. What would you do? Collagen cross-linking. So collagen cross-linking to me is a wonderful technology. I've been involved in it for over 2 decades abroad before its US FDA approval, used every possible technology. The mistake that is happening nowadays, and what's really compelled me to accept this invite for the webinar tonight, is the number of patients who are flying to me with complications and very disgruntled with their surgeons because the surgeons explain cross-linking as a treatment. It's not a treatment. It's a permanizing procedure. In fact, you should not do it without fixing the cornea. So here's my keratoscoliosis concept. If you see this concept here, I'm explaining how, if you think of a keratoconus cornea as a scoliotic spine, it does not make sense that you're putting cement on the scoliotic spine and telling the patient this won't bend anymore. Well, that's okay. But what about straightening the spine before you keep it permanently bent? That's the concept. If anything else you walk away with tonight from the webinar, if you understood this concept, thousands, maybe millions of patients could be saved the blindness and the severe pain they are feeling from being let down as they fly to me. So cannot cross-link a patient, keeping their cornea in a keratoconus situation. Literally, you're maiming the patient, disabling them for life, and then handing them over to contact lenses or telling them they're delaying their transplant. That is not even a goal. It's a very poor goal. In fact, it's not a right thing to do at all. Fix the cornea and then put that cement across link. So this is my keratoscoliosis concept that makes a lot of sense the way I treat patients and have been fixing a lot of complications lately. So I'm a big proponent of cross-linking, but that's my stance for it, that it should not be done the way it's being done right now all over the world. Doctors are just indiscriminately doing cross-linking, putting the patients permanently disabled in their cone situation and handing them over to a permanent dependence on contacts. And this is the man we owe the cross-linking knowledge to, Professor Theo Seiler, amazing gentleman, and had the privilege of knowing him for a very long time. And it's really, we owe him a lot for this amazing work. And the biggest thing coming into my institute nowadays is dozens of patients with cross-linking complications, not only from the fact that it did not work or kept the patient improperly balanced in their vision, but also complications like scarring and irregularity of the cornea. All of this can be fixed. Let's move on to the next level now. Any questions up till now, JD?
Yes, Dr. Gulani. One quick question, and I think you'll like this one. Do you have an astigmatism limit that is too high for structural treatment?
Do you have, sorry, what was the word there?
Do you have an astigmatism limit that is too high
No.
for structural treatment?
No, I'll come to that again. These are all limits placed by surgeons who really don't understand anatomy. They've kept these numbers because that's how they were taught. Again, I'm just giving you my personal example because 80% of my practice is fixing complications, and really, I have not seen any of this happen. In fact, what I tell surgeons is if you see a pole, you want to do a pole vault to 6 feet. If you see 9 feet, jump 9 feet. There's no such thing as that's too high. And land somewhere close to it. You just saw the first case I showed you was 24.5 diopter astigmatism. I just did a patient of 34 diopters. It doesn't matter. No matter how high it is, it's our job to tackle it. Cannot get scared. And there are ways to do it. We'll talk about it. By the time I'm done, you will understand that you can even combine technologies, toric lens with Intacs, with laser. Never had to do all these three, but yes, there is no way you're going to be defeated by astigmatism. No way. Have I answered that, JD?
Absolutely. Thank you, Dr. Gulani.
BCVA less than 20/60, best correct. And remember, please, for a shortage of time, this is actually a 4-hour course that I've combined into 45 minutes for you. So I'm going a little fast, but please get the message today. The message is your keratoconus patients can see. There is no such thing as a severe keratoconus or too advanced or too complex. And if you get defeated, I will not tolerate it. So vision. What I do with keratoconus patients, even if you send me a 90 diopter keratometry like I did this week, I start refracting them. I don't even look at topographies and stuff like that. I just start refracting because my vision is the biggest thing that diverts my attention between structural and visual. See how simple it is? Do you have to structurally arrange the cornea? Do you go straight to vision? So if the vision, I cannot, with my refractive abilities, with the straight retinoscope, I have all the technologies in the world that are, many are not even approved in the US yet in beta mode. I have so much stuff in my institute, but still I use my streak retinoscope as my first set as I attack the patient's situation. Are we clear about this? And yes, I refract them personally. So if you're willing to take these patients to perfection, you must know, like I say very loudly, a refractive surgeon must know how to refract. So if the vision is less than 20/60, refractive errors, hyperopia usually, and astigmatism, less myopia, pachymetry more than 250, unstable, irregular topography, and ectasia or anterior scarring, I go to Intacs. No lamellar keratoplasty, no laser, no visual surgery now because the cornea is not sensible. Everybody with me? It's not sensible. If it's not sensible, it is incorrect on our part to aim for vision because you're shooting in the dark. So you want to stabilize the cornea, give it some strength, build it, and then go to vision. So Intacs, the way we do it, the Gulani Donenfeld technique basically is you can sit at 12 o'clock and you can enter anywhere. And there are various ways of doing Intacs that I've defined before: laser, manual, single, double ring, a steep incision, flat incision based on posterior curvature. All those things I will discuss in another webinar, the techniques and my parameters. There, I've committed to another webinar. This whole webinar, I want you to understand that it's possible to bring people to vision. Now, you can see immediate reactions of these patients. This is my titratable Intact technique, I call this, where as I put the ring, I can see the reflex and the patient reaction. Watch this again. And that's a ReStor sealant. I don't use stitches.
Just put a pencil ring to control your complication because they look at the light. Can you tell any difference? I can tell her hair right there. Wow. And I can see the square around that. See that square ring around that person knows where.
See that immediate reaction, just like I showed you in the first patient. This ring is going in to control the 70K keratometry.
I think, come on, give me a smile. Tell Kelly, keep crying, I don't want it. Get up.
I want you to remember these things because you can change these patients' lives either way, either telling them for years that nothing can be done, staging their keratoconus and writing down in your charts, or actually fixing their vision. This patient from Abu Dhabi from 10 diopters brought to 0.1 intact technique. Patients with LASIK, again, like I told you, I don't differentiate. I don't waste my energy grading and staging and going over parameters on a topography. If there is vision, go visual. If you cannot get refraction, go structure. So if you see this, how even LASIK ectasias that are flown to me can be brought down straight to perfect vision. Here again, 23.5 to 1.4. This patient also had ectasia, scar, everything, modified T intact technique, straight to 20/30. ALK surgery, doesn't matter what the surgery is. If there's ectasia or keratoconus, go and perform the structural correction. Again, it doesn't stop there with me. Once you put the rings in, many patients are flown to me, they've had intacts, and the doctor says, doctor, this technology doesn't work, it fails. I'm like, no, you left refractive errors there. You can do laser surgery on top of the intact, use a smaller ablation zone, go and correct the astigmatism, most usually that's there, removal of very few microns, and straight to vision. In these cases, 20/20. Patients flown to me from abroad with this kind of scenario. The ring is broken and the surgeon just panicked. This is the Ferrara ring. It's used abroad a lot. In the US, we don't have it available. And the ring's broken and the surgeon panics and the patient is not seeing. The issue was refractive. So I told the doctor, you've done a great job. Don't worry, the ring is still fine. Not going to remove it. Let's laser and correct the patient's vision. And that's what we did. Here's a patient from Egypt who came with multiple surgeries of keratoconus. Again, intelligent colleagues of ours, but they spent all their energy without GPS. One surgery after another till the cornea was thinned out to 200 microns. All kinds of cross-linkings on different varieties. A full, this is called a Kera ring. It's a 360-degree ring. All these things that there's no vision. Laser surgery straight to vision. And this is what I do for patients who are flown to me with failed intacts. It's not really a failed intact. It's a residual refractive error. Any questions there, JD, before I go to next level?
Not at this time, Dr. Gulani.
Lovely. So next level from here. If the vision is less than 2100, this is all in my mind, okay? And the refraction I just cannot get. I'm sweating in the room for 30 minutes. Patient has landed from somewhere and I'm just going on refracting. I get nothing. Pachymetry 200 and less, stability unstable, irregular, with scar and ectasia. Now, I cannot put an intact because there's a deep scar and nothing is measurable. I don't even know where the steep or flat is. Now, it's improper for you to do that surgery. You go to lamellar keratoplasty. A simple surgery takes about 16 minutes with topical drops with simple 2 instruments that you need, and you can do it in these patients, and they are blown away with the outcome. So lamellar keratoplasty can be automated, as you can see here. You cut a little flap onto the patient like a LASIK, throw it away, and add a tissue that's about 2 times thicker. And what does keratoplasty do? Lamellar, never penetrating. Penetrating keratoplasty, you don't want to do. Disables patients, never gives them 20/20, and you restrict the patient's lifestyle. All right? So lamellar keratoplasty, what it does is decreases the keratometry, removes the scar, adds tissue for your future laser correction. Here's a hand lamellar in a very thin cornea. This is a 100 micron cornea.
This is a case of a very advanced keratoconus.
I'll just go fast on this just so you can see. And hand lamellar is an excellent technique you can learn. Again, just 2 instruments needed, a tooth blade and a forceps, and you can do your dissection. And there you go. And then you put in an anti-torque suture, Barracker anti-torque suture. Patient is ready for you. And you get ready to do whatever you want after that. Lens-based surgery, laser-based surgery, and straight to vision. So various kinds of lamellar, including posterior lamellar surgeries and keratoconus. Refractive, please, refractive. Now we go to combination techniques. So again, like someone asked me here, I have no limits. This patient from Switzerland was sent to me for keratoconus, congenital cataract, high myopia, high astigmatism, high keratometry. What do I do? Because she was not measurable and everything was high and improper, I could not do the cataract surgery. It'd be a disfavor to the patient because I'm doing surgery without intelligence. So I first stabilized her cornea with intacts, brought the case down, corrected the astigmatism, made her measurable. Remember my words, measurable. And then went in and did the surgery with a toric lens straight to vision, as you can see here. See the little video right there. And again, very simple surgeries, but see the GPS, the planning system. You cannot do the opposite. Going inside the eye is sacred. You cannot do a mistake there and then grapple on top. You correct the top first and then go inside once and for all. Let's go to this patient. This patient had had 12 failed procedures for keratoconus, right from multiple cross-linkings to PTKs, the finally anterior scars, intacts, ICL, you name it. And when he came to me, was desperate, depressed, what do you do? And had a cataract too. Again, remember, just because the other surgeon has done these surgeries, you don't blame the surgeon. You just look and see what is good out of this. Though the surgeon did the surgeries well, the GPS was missing. They did all these in different orders that did not make sense. That means the car went in reverse and sideways, but it didn't really move forward anywhere. Patient is confused, very angry. Now, you look at the situation and go, all right, the intact's already in. So it's stabilizing the cornea, the keratometry is low. There is a refractive error, and ICL, as you know, doesn't affect the lens power when you're measuring for the IOL for cataract. So I said, let's leave the intact rings. We did laser surgery to remove the scar and make the cornea measurable. Then I went inside his eye, removed his ICL and the cataract, and did a staged cataract surgery because I still didn't believe my technologies for a lens calculation. That's his ICL coming out. Again, all surgery has to be elegant. I leave him aphakic, and that's again ReStor sealant. There he is, immediate. A week later, after measuring him refraction, I do a lens based on the secondary lens formula. Put it in, ReStor sealant, again no stitch. Patient remembers stage surgery, 4 minutes each, and straight to 2020. So there is no limit to how you can fix these patients. Again, see the process. Patients trust in you. I showed you that patient of going from Orlando to Paris, in between to Iceland. This is a progressive front. You're not making it worse, but you're going staging forward intelligently using GPS, completely disregarding the stage of keratoconus. Of course, you can work with optometry. This is a great branch, keratoconus, where if you don't reach your endpoint, you can always have great technologies that optometry has today, like scleral contact lenses, 3D prints, and they can do these and add to your surgery and keep these patients at 2020. So with that, I end exactly on time. Thank you for your attention. And you can always contact me for any questions. JD, I'll let you take over from here.
Oh, Dr. Gulani, we always have plenty of time for you. Let's see. You said it best, Dr. Gulani. There is no one way to solve an eye, but you have surely laid out the method behind your approach to keratoconus with proven results. We cannot thank you enough for all of your sharing your incredible wealth of knowledge and experiences with us today. For the audience, in a moment, we will pose your questions to Dr. Gulani. If you haven't done so already, please submit your questions now. Once again, you can do this by clicking on the tab that says Questions. Then click on the plus sign that will open a text box for you to write and send your questions. So Dr. Gulani, we'll hop into a few of these now, and I'll try to do my best to keep them in the order of your presentation. One recently came in. When do you remove sutures after anterior lamellar keratoplasty?
Excellent. So again, each case is unique. Keratoconus, as you know, each cornea is unique. So I look at the stability. I start at 6 months because lamellar, when I do it, I get the feel. I just did a surgeon, in fact, yesterday, I saw him in post-op today. Cornea was so poor. And again, cross-linking, if somebody's done, the whole corneal metrics change. But I wait at least 6 months. Can even wait up till a year. Don't be in a rush. Remember, you have built the structure. You have built the structure, but that is your midpoint. It's not your endpoint. You are aiming for vision. So if you make a mistake in removing the suture or disabling your lamellar keratoplasty, you damaged all your hard work. So my answer is 6 months, but with that caveat, watch it carefully.
That's great. What is your lower limit of pachymetry for doing laser with or without intact ring?
Another question that doesn't make sense ever. So remember, I always say this, is a 5 feet tall guy tall or short? Relative, isn't it?
It depends.
Nobody gets this question. I speak about this, and when thousands of people are with me in auditoriums, and they all get stunned. This complete nonsense about a pachymetry number. There is no such thing. A 4 feet tall guy is not short, is not a dwarf, is not an abnormal person. He's relatively short. Similarly, a 7 feet tall person is relatively tall. That's not a giant. So as long as the cornea is not abnormal, you are fine to come down to 300 microns. I've done this for 3 decades. Anyway, let's give you another caveat with this. In keratoconus, the biggest refractive error is astigmatism. Now, if you understand the laser physics, it removes the least amount of tissue in astigmatism and actually gives you an oval optical zone, which is large enough to give you great night vision. Now, use your logic. You do not want to do 5 diopters myopia on keratoconus. That's why if you see my protocol, astigmatism over myopia. Maximum myopia I will do is 3. But that's not a limit. It's based on each cornea. And what is my plan for the next stage? So let's give you an abstract way of giving you limits. 3 diopters of myopia on the keratoconic cornea. Astigmatism can go up to 6, 7, doesn't matter to me, as long as the patient is refractable, measurable, and stable. If you have any concerns, cross-link the patient after 3 months. Don't directly cross-link because you did, first of all, a surgery that wasn't needed. Second, your laser surgery itself gives them enough stability and you're observing them. But don't let them fall beyond the 20/20, therefore 3 months. Does that help you? As long as the cornea is not abnormal, remember that. That's the caveat that doctors don't understand. They still debate on pachymetry, and then when I enter the auditorium, it goes pin drop silence because none of them have an answer. People talk about 512, 52, 520. Who decided that number? Who decided that number? I have patients of 100 microns who are still doing fantastic. Patients of herpes scars that I've done laser on. So what I'm trying to say is don't go that far. You'll need experience for that. But point is, look at the cornea. If it's abnormal, you don't want to do any cutting surgery. But you can do laser surface surgery for sure. For astigmatism, not so much myopia because you don't want to remove central tissue. Not hyperopia because you'll increase the keratometry. So you see, when you plan like this, among 40 techniques, innumerable technologies and combinations, every patient becomes a fun candidate for you.
That's great, Dr. Gulani. And a question just came in, I think that's pretty pertinent to this discussion. When you correct vision with laser, are you referring to PRK or LASIK?
So I just said, never LASIK. It's a cutting procedure. There are about 23 laser vision techniques that I teach. LaZrPlastique is the one I use for keratoconus, but yes, it's a surface laser surgery. And please, never a cutting procedure. I get this all day. I get 15 to 28 emails a day from surgeons who are still continuing with this confusion. Can we do SMILE then? Understand, SMILE is not a right direction. It's just a entertaining side turn in evolution of refractive surgery. It's fine. Okay. SMILE is still a cutting procedure. You don't want to do that in a weak cornea. Surface procedure will help you because the epithelium is your friend. The biggest refractive layer you'll find is your epithelium, the most protective layer. That's why I do scars and RK people, and they all do so well. So never a cutting procedure, superficial technique, yes, and mitomycin 100% of the time.
Got it. After inserting Intacs, what time or how long do you wait to start treating vision? I know you're going to love that one.
Same thing again, remember. See how I taught you today. You don't have to listen to any talk, any confusion, any classification from anybody because all their complications are sitting in my institute. Hence, I want you to be very clear that you can do everything. It's very simple. Don't complicate life for you. So I just mentioned 2 words to you, measurable and stable. Once your cornea is measurable, meaning you can refract through it, and it's stable, meaning it's not changing, attack. That's your time, attack. Similarly, once my vision is reached at 20/20, from whatever technique I did, many of my intact patients directly land on 20/20. Once your vision's landed at 20/20, be very focused. If the patient is young, if you need to cross-link, don't lose that window because you don't want them to fall to 20/40 and then you cross-link. So you see how I think of cross-link? The only 2 indications, one indication is the one I've just taught you, which is harmonize your procedure. Once you've corrected the spine, put the cement right there, cross-link. The other only option or requirement for cross-linking is changing cornea, either younger patients or while the cornea is so unstable, you can't make out anything about it, what's going on. So you want to stabilize it and then measure it. But most usually, please use it after fixing the cornea. Your patients will love you. As I said, the whole drive for this webinar is the number of patients who are flying to me with complications, more important, disgruntled with their surgeons is unbelievable because the doctors are getting away saying they're going to cross-link. Think about this for a minute. You have an only child, only son or only daughter, all right, 26 years old and has keratoconus. How smart do you look saying, I'm going to cross-link your keratoconus so it won't get worse. This is a new technology and I'm the first in my little town in Timbuktu. Now, the mother asks you just a simple question. You're going to permanentize his keratoconus so it doesn't progress anymore. But aren't you keeping him bent forever? Think for a minute, guys, what I just said, my keratoscoliosis concept. First, fix the cornea, make it straight, give it shape. Shape is vision. Remember, myopia flattens, hyperopia steepens. Shape is vision. Then cross-link it. Cross-linking a cornea and telling the patient, now here's a lifetime of dependence on contacts, and here's your final disability of transplant. Wrong. I just showed you patients of keratoconus who are seeing. And if you don't land on your outcome because it's really far gone, you use your optometry friend to help you put in a contact lens. No, nothing wrong with that. But at least fight the battle. You can't start with a contact lens and go, here you are, your bone is bent, I'm going to put you in a crutch and see how well you walk. But every time he takes off the crutch, he can't walk, he's disabled. And the bone is getting weaker underneath that. So patients are coming to me at such end stages now. They have scars, cornea is down to 100 microns, they've had 3 cross-linkings and they've been in contacts. Now what can I do? It becomes difficult. Still you can help them. My point is, why let them go at that level? You get me? So that's the way you got to approach. Stable, measurable. Surgery is very simple. Structural, visual. You see how simple it is? Don't need to listen to anything else. And do not waste your energy thinking how to cross-link. Debates at national seminars. Epi on, epi off, nonsense. Everybody knows what works. All of them are confused about when to use it. That is the challenge that nobody has addressed. When do you cross-link a patient? It's an amazing technology, but you cannot cross-link a keratoconus and leave them disabled for life. That's a crime. So understand that concept. So simple, measurable, stable cornea, attack. If you need to protect it, cross-link. Structural, visual surgery. Structural can be corneal lamellar surgery, intact, which is a directional lamellar surgery, cross-linking. Visual surgery could be your laser techniques, ICLs, IOLs. The IOLs could be whatever, piggyback, whatever kind of lenses you want. So if you look at it so simply, you walk into your kitchen, you're a master chef to every patient. That's why think outside the cone.
Absolutely. Interesting question. How do you approach a patient with inferior steepening concerning topography with a normal pentacam?
You see, was this guy sleeping when I was speaking? So I just told you, what do I do when I enter the room? These patients come from all over the world, and what do I do when I enter the room? I start refracting them. I do not look at anything. I have all the kinds of OCTs, topographies that you haven't even seen or heard about. I don't look at them. As I've said before, just today morning, a patient from London emailed me, amazing, amazing, but I'm so used to this now. 6-page report from their doctors, very, very intelligent colleagues of mine. What have they done? Throughout the 6 pages, they have staged the keratoconus based on OCTs, topographies, new models. What is the treatment done? Continue contacts, dry eyes. Unbelievable. I don't care if it's inferior steepening, temporal steepening, posterior steepening, superior flattening. I don't care. Can I refract the patient? If I cannot refract, you're going structural. If you can refract, you're going visual. How simple is this, doctor? I don't look at the topography. I look at it to teach you, show you pre and post, and show you the drama that happens, but that's not the point. Refraction is the drama. When fellows come to watch me, surgeons come to watch me, they stand unbelievable because that's your power. So please, topography, great adjunct to your planning. It is not your diagnostic planning. And don't go by all these nonsense criteria. This and that decides your cone and what's the level of the cone. What if you miss it? I'm always protecting surgeons in depositions. Nobody holds that any water. Do you know that? What was this criteria of your cone? It's very simple, man. It's a clinical diagnosis. If you cannot refract to 20/20, you see a scissor reflex and you see a Wilkes ray, that's conus. If you see astigmatism against the rule, please, it's a red flag. You don't need anything else. You see how simple it is. And I just told you, I have every technology on this planet. I'm teaching you to be the Bruce Lee. Just go into the fight and win. Cannot sit like a wimp and go, this topography is so dangerous, this OCT looks so bad, this patient has great for keratoconus. Now, what are you going to do? Nothing. Today's webinar, the reason I'm saying and speaking for such a long time is get the fact that you can do it. None of these are difficult surgeries. Just get your mindset to perform. You'll be amazed. And if you call yourself a refractive surgeon, keratoconus is refractive. surgery.
Great advice, Dr. Gulani. One of our audience members is asking, what kind of PRK are you using? Topo guided, Wavefront customized, or do you have another trick up your sleeve?
Again, if I show you my sleeve, you'll go crazy, but here's the point. We'll talk about this, like I said, in the next webinar, how I select technique, technology, parameters, and plan. For now, please. Wavefront, when it came out, we were among the first in the world to do it in 2001. I said it at that time, 8% of people may need it in the entire world population, and it can never take off because Wavefront addresses molehills on the mountain. You guys are missing the mountain. So Wavefront has a role, but Keratoconus is a mountain of refractive error. Topo-guided is a total loss. Here's my single lens sentence to you, which is an award-winning video, but I'll give it to you right now. Topo-guided refractive surgery is as intelligent as mirror-guided tailoring. How's that?
And could you repeat that again?
Topo-guided, topography-guided refractive surgery is as intelligent as mirror-guided tailoring. Have you heard of Michael Jackson? Doctor, man in the mirror, remember? And there's a video I made for this, which I said, fix the man in front of the mirror, not the reflection in the mirror. Fix the suit on the man. So looking at topography and fixing topography doesn't correlate with vision. Refraction equals vision. Can you look at a topography and tell me the patient's vision? Answer is no. Can you look at refraction and tell me the vision? Answer is yes. So hit where it hurts, refraction. Topo-guided people are getting some results because most of it is refractive. They are still not understood the fact that that's a total misdirection. I've been fixing topo-guided problems for past 20 years now from all over the world. Patients, again, very angry. They've paid thousands of dollars. They were told to go to different countries. They all fly back with zero vision, but good-looking topographies. So you get my point of mirror-guided? The chart looks great. Patient is blind. That's not what the patient's looking for. Refraction equals vision. That's the point, doctor. So no wavefront guided, no topo guided. Refract the patient. You'll be right all the time.
Great, Dr. Gulani. Here's another question. How frequent do patients with intacs complain about night visual symptoms, or do they create enough visual aberrations to alter any night activities?
Right. So remember what I said again? I'll take you back to simplicity. Every time you try to go complex, I'll hold you and bring you back. How's that? So doctor, I just told you structural visual. Intacs is a structural surgery. Your visual aberrations are not because of it, or this is not even there to correct it. So see how you're completely lost. Your visual surgeries are the ones that address vision. Your intacs, in many of my cases, brings them to excellent vision, even 20/20 in many cases. But that wasn't my promise to the patient. When I use intacs, I tell them, you are 8 feet tall. Let me bend you down to somewhere close to 6 feet. You might be coming to 7 feet, you might land at perfect 6 feet. Either way, you are good enough to go into the mall and pick up the suit from the rack now. Before you couldn't, right? 8 feet tall. Now, it is not a custom tailored suit though. It's going to be short a little bit, baggy a little bit. It's not custom tailored. That custom tailoring now comes after the suit is on you. Now that you're somewhere close to 6 feet, now you design the vision. See what's the cause of the aberration. There most likely is a refractive error. Increase the optical zone, myopic astigmatism treatment, or go inside the eye, correct the treatment. Patient may have early cataract, whatever they have. Visual is a different system. Structural is a different system. This is like saying, doctor, when you do lamellar keratoplasty, what about the vision? Vision is not the goal of lamellar keratoplasty. In my 5S system, it's a build-up surgery. It removes the scar, adds tissue for future treatment, visual, right? And corrects the center elegantly in 16 minutes with topical drops, with an anti-torque suture that looks gorgeous. You just built that patient's cornea for vision corrective surgery. So intacs is not a vision surgery. If a patient complains of night vision, look for the cause, correct it refractively. If there's a scar, go after LaZrPlastique, fix it. Very important. So understand the difference. Vision, structure.
I like it, Dr. Gulani. Keep it simple.
Simple.
For our next question, are femtosecond laser-assisted astigmatic keratometry arcs an option to treat astigmatism in your keratoconus patients?
Doctor, I just said it. No cutting procedure in keratoconus. You cannot cut the cornea. It's not about how much you cut. No cutting the cornea in keratoconus. You're disabling a brittle back. How's that? A spine that is brittle. Even a small cut that you make makes it a little more prone to fracture. I'll be very clear about this. I just gave you an example of smile questions that I get all day. Smile cannot be done. Astigmatic keratotomy should not be done. No cutting procedure because the cornea is fragile. Remember? It's just brittle. Let's call it brittle just for our discussion. You can shape it with laser on top. Don't cut it anywhere because now you're leading toward chasing the tail, literally, because you don't know what happened. That cut makes it a little more. Also, the reaction is not according to a nomogram because the keratoconic cornea is a different kind of cornea. So there are main reasons I want to simply put for you is do not cut a keratoconus cornea. Shape it, play with it, mold it. I call that keratomodulation. With whatever way you want, don't cut it.
Don't cut it, but I am cutting to the next question. Any role, that was good, any role for corneal allogenic interstromal ring segment or CARS implantation over Intacs, in your opinion?
Again, I don't care if you use a drawstring, that you have in your pajamas. I have no problem there. I need a structure. See how I speak, guys. It's very simple. That's why it doesn't matter when I'm abroad if I use a Kera ring or if I have to fly in or if a patient comes with a Ferrari. Doesn't matter. Doesn't matter. You want to put a piece of your hanger into the cornea, I'm okay. Give me structure. Don't complicate your life. Don't make it so confused. I gave you such a simple plan today. Laser, vision, structure. Anything that can hold structure in the cornea for me, whatever's available to you, use it. Use it. Just, of course, make sure it's not reactive, it's properly approved, all that stuff. But so it doesn't matter. If it works for some doctor, excellent. Whatever's available to you, just give me structure.
Absolutely. Dr. Gulani actually received this question a few times in a few different manners, but quite simply, are you ever electing to use only one intact segment versus two? And please explain what patient population or patient presentation you would elect to do that in.
Absolutely. So again, this is going into parameter and planning, which I wanted to keep away from today to keep the mindset going towards vision. But yes, doctor, I do. And a quick snapshot, I have about 10 to 11 parameters, how I pick all those things. But briefly, when a patient has very high astigmatism and asymmetric cornea, I use single ring. All right? Excuse me, when I want to decrease the keratometry big time, like the recent patient I did 90 diopters, 86.9 diopters keratometry, I use double rings. You saw that case I showed you with the hex K, where the patient was over like nearly 90 diopter keratometry, 24 diopter astigmatism. I use two rings to hug the hexagonal keratotomy. So I constantly think like an artist or like an architecture. I think always as structure. How can I lift the cornea from one area without giving the other area any leverage? Single ring. How do I decrease the keratometry big time and decrease myopia and keratometry without affecting astigmatism much? Two rings. Again, there are other caveats, steep, flat axis, but in briefly, that's how I go.
Dr. Gulani, are you using scleral contact lens?
I don't. But if a patient, a lot of them, like I said, come from other surgeons elsewhere, and then they go back to their city states. If I have not reached 20/20 in some patient, my drive, JD, in all patients, and I absolutely will let them go into scleral contact lenses, or optometrists have great things nowadays. Scleral contacts, they have these 3D print lenses that you can actually print, do an eye print of your eye and do a contact lens. Great technology, and it's very, very complementary to what we do. So I'm totally for it. But what I'm teaching tonight is for surgeons is first fight. Get your fight done. Give it all you have with the least intervention. That's corneoplastique. Least interventional, most artistic, aesthetically pleasing, brief topical surgery to perfect vision. If, and I'm calling it failure just for ourselves, because I want us to have our confidence without guaranteeing the patient, because the patient knows it's a very difficult situation, but you want to guarantee to yourself to fight. If you don't reach 20/20 in any scenario, and again, remember, I'm not calling it mild, moderate, severe, any scenario, scleral contact lens can help you. Yes. Because remember, you haven't left the patient completely disabled. They can function. Even if not 20/20, they're blown away. They can function. I've shown you patients who are surgeons, attorneys, all kinds. So as long as they can function, what is improper, I call it criminal, is you don't fix it and you cross-link them and put them in a contact lens. That's wrong. They surely can see and function, but every time they remove that, I call it Superman suit, there's a 40-inch waist outside behind that, which is disability. They can't function without it. And you told them that only reason you're doing this is to delay a transplant. Very low bar. Very low bar. We must fight for vision. It is there, possible.
That's a great point, Dr. Gulani. And you mentioned cross-linking. If a patient is unstable, would you ever place Intacs and watch the patient for stability prior to performing then cross-linking?
Sure. So again, I go back and back and back all the time saying exactly what I've said. Cross-linking to me is a permanizing procedure. I call it, when surgeons come to me, I tell them, think of it as it's in your back pocket. The minute you've got this cornea or the spine perfect in shape, attack if you need to. Don't just do it, that's a cocktail. Don't mix it, except in the cases I showed you, where the reflex is so perfect, you can do it. So my reaction, as I said, look at how I think, again, structure, right? Now we're talking structural surgeries, not visual. I will use the Intac where I want to correct the astigmatism because it's directional. I just talked about single double ring. The cornea has maybe anterior scar, but not full thickness. The cornea is unstable, cannot make sense out of it, more hyperopic than myopic, Intac, which is majority of these cones from moderate to severe. Now, if the patient is just unstable, but I can refract to 20/20 or 20/30 or 20/40, now I will cross-link and then do laser. Again, if the patient wasn't unstable, but 20/40, 20/30, I will do laser, get my vision. Now I will watch for 3 months. If there is any drop or change, I will attack with cross-linking. In fact, I call them in at a time when they tell me, the doctor, this time of the day, my vision is excellent. I call them exactly that time and I cross-link. You get me? Cross-link, think of it as an amazing technology, but it's in your back pocket, not to be used unless needed. Do not allow this indiscriminate cross-linking that's going on all over the world, which I'm seeing now, and patients flying to me. It's not right. You're cross-linking people, leaving them blind. They can't be in their profession. Then you told them, this is it. That's wrong. Tonight's webinar is very focused. I want you to understand keratoconus is a refractive disorder with associated thin cornea, high keratometry, and irregularity. See, if you think this way, how your whole mindset changes. When you call it keratoconus, half of you just get paralyzed by that word, and then the patient loses hope too. You walk into a room and go, this is keratoconus. That means you have high myopia, astigmatism, presbyopia, maybe early cataract, and high keratometry, irregular cornea. You see how you think? Your mindset changes. It becomes, you take a giant and you think of it in your mind as a snicker-eating, boxer-wearing dwarf. And one kick and it's out the window. Can you have that mindset for me? Get to work. Get these guys to see. Keratoconus patients deserve vision. Got to get to work.
Definitely a good, a lasting visual there, Dr. Gulani. Just two more questions here as we are coming up on our time for this evening. And I think you'll like this one because you have asked a few times if we were paying attention. This question goes, earlier you said that first correct the shape of the cornea, then apply preferred surgery. What about those patients who have already undergone, such as cross-linking, without shape cornea correction? What can be options for such patients for vision correction having high myopia, such as 8 diopters or greater?
Lovely question. So as I said, the incentive to accept this invite for this webinar was that I'm seeing a tremendous increase in keratoconus complications coming to me all over the world. And it's the same pattern I'm seeing from surgeons. Indiscriminate cross-linking, total lack of accountability, and the patients left to fend for themselves, contacts and transplant. In fact, if these poor patients, they come to me nowadays, they even record their videos and send me an email. It's very sad to see them crying and yelling. And it's fascinating. There has to be accountability for what's going on. These patients deserve vision. Now, when they come to me, as you know, I just told you, nearly 80% of my practice is fixing complications, whether it's Lasik, Smile, Cataract, K-conus, RK, whatever. I completely disregard what was done before. I don't care. I don't go on wasting my energy. Show me which surgeon, which country, what technology, it doesn't matter. Here's one caveat though from my experience. Haven't published it, but caveat. my ability to take these patients to 20/20 goes down. I have seen that they don't reach 20/20. They somehow stay at 20/30, 20/40. I think because of the cross-linking, the reactive, or should I call response to my surgery, does become a less predictable. So it's a disservice that the patient had cross-linking before they came over to me, but that is not a deterrent to me still following my protocol. Does that answer your question? I still am going visual structural. So even if it's cross-linked, but I can see 20/40 vision, visual. Cross-linked, but it's all bizarre, structural. So I'm not changing, but I do know the ability for that patient to reach 20/20 is a little lower.
Great answer. And I definitely think it answers the question. Quick question for you. What type of corneal cross-linking are you specifically using? I know you mentioned epi-on, epi-off. What about thin corneas? Any additional information or feedback from that question?
Again, doctors, you'll keep going back to technology and stuff. Like I said, I'll do it for you next time. But here's my point again. Do not get too bogged down with the technology. Do not. I have used every technology ever made. Most of it, many of you will never even see. I'm giving you a straight answer. Doesn't matter. You know what cross-linking is? It's a $10 torch light and maybe a $2 riboflavin drop. That's it. You can do it with that too. I have done it in pro bono areas abroad. No big deal. Yes, I have the most sophisticated technology. In fact, I have two of them. That's not the point. And I use epi-on, epi-off in extreme cases, which I have to. Absolutely, that works much better. But most cases, epi-on works pretty good. But please do not get into that debate. It's brain dead debate when you don't know when to do it. What's the point of knowing epi-on, epi-off, and these conferences that are being held, and every speaker's patient is sitting in my institute wanting to sue them? I'm doing this webinar to help those doctors. Cannot keep talking this absolute nonsense. This technology, that technology. Cross-linking is an amazing adjunct to your entire armamentarium of keratoconus treatments. Think of it that way. Do not get bogged down. Whatever machine you have will work. Epi-off works for extreme cases where it's real desperation. I rarely have to do that. Epi-on works for nearly all cases. And again, remember, the vision you got with your visual surgery, not the cross-linking. Cross-linking was an added benefit to solidify, permanize keratoscoliosis concept, right? So please don't get into those discussions. Not important. All the doctors are missing the main discussion when to cross-link. Biggest discussion of tonight should be, oh my God, my patients actually can see. I had assumed that they should be admitted in the vision asylum. Incorrect.
You did say to keep it simple, Dr. Gulani. For our final question of the night, it is rather broad, but I'm sure you'll have a response for us. You've discussed a lot of different procedures, and the question really just states, as far as insurance coverage.
So again, insurance depends which procedure is covered. Intacs somewhat are covered, certain insurances covers them. Cross-linking, again, the same problem we are having in the country, covers, doesn't cover. Laser procedures, mostly are refractive techniques. Lamellar keratoplasty may be covered because that's like a corneal transplant. All these things are variable. Do not let that make your decision. You'll be surprised, guys, because I see all of your complications. Patients actually are willing to pay for a procedure as long as you are doing the right thing. They have lost money going in for cross-linking and stuff without knowing that that wasn't vision. Once again, cross-linking, great technology. I'm just seeing so many complications come in, and every doctor is just unaccountable. I'm just getting these notes and notes when the patients bring in and they're crying. They spend thousands and they're not seeing. Now they have to buy contacts. They're waiting for a transplant. And if you see these patients and their emails, you know what they talk about, these poor keratoconus patients? They talk about, oh my God, I'm having my transplant today. I'm so lucky. Really? You're lucky? Your life now is disabled. You have stitches, you'll have astigmatism, you'll wear a contact all your life, and you can't lift, bend. If you ever get punched in your eye, 40 years later, it'll still pop open, and rejection. You're not lucky. Oh, I'm going for my cross-linking today. My question, how about your vision? Nobody has talked about vision. Everybody has assumed that keratoconus patients are supposed to stay blind, and we are doing a service by sending them into contacts and delaying their transplant. Very low bar. The bar is on the floor. Think vision. Think vision. So insurance and all these things, the reason this is important and not important is when you explain to the patient what you're doing, They will come up with the price or the cost or whatever. Help them out. These people need help. But don't let that decide blindness. It's huge. It's huge. So please understand, every time you guys are questioning me, which our questions are wavering, I try to bring you back into the focus. The focus is vision. Don't worry about anything else. Talk directly to patients. If your integrity high, you have results, and you're known for that, patients know you, they trust you. They'll sit down and go, wow, this makes so much sense. Why will you not fix my spine first? Why would you put cement and leave me bent forever? I can't walk straight ever after this. So doctor, insurance, money matters, all these things important, not important as long as you look for vision. You do the vision, look at these patients, attack mode. When you give them the vision, they can earn the money, change their lives.
That's great, Dr. Gulani. Keep it simple, seek vision first.
That's it.
I want to thank you and obviously our engaged audience tonight for some really great and thought-provoking questions. Following tonight's session, we will email you a link to access the recording of today's webinar and a survey soliciting your feedback. We ask that you take just a few minutes to complete the survey, as your comments will help guide us in presenting the best possible educational webinars as we move forward. Once again, many thanks to our phenomenal guest, Dr. Gulani.
Thank you so much, Eddie. Thank you so much for the invite. It's been a pleasure.
I also want to say thank you once again, everyone, for participating. Please enjoy the rest of your evening. Take care, be safe, and have a great night.